This is Heart Health Month. More people die of cardiovascular disease than any. In fact, if you look around the world, it's almost double compared to cancer. So it's way out in front. And part of that is the fact that we capture all of this late. We manage the complications of cardiovascular disease, but are not so good at the front end of this. And so it's the concept of cardiovascular risk detection and screening. What role should it play in the way we practice medicine? And again, we've got a number of people here on the phone, some emergency room, but some primary care docs. What should it play? And we've added a couple of new faces that are a little bit different. And Jeff, I'll start with you. I want you a quick introduction of yourself, and people may be surprised. You're a little bit of a fish out of water in this group, but I'm very happy that you were willing to jump into the tank with this group.
Hey, hi. Jeff Bennett, CEO of Higgy. I am not a doctor, so maybe that's the fish out of the water piece of this piece. CEO of Higgy, we have a consumer health engagement platform, which has really been empowering consumers to measure and track their data, educate them on cardiovascular disease and other chronic conditions, and better manage that through community locations and retail pharmacies, grocery stores, and through home devices. So great to meet everybody on the call.
So Jeff is the person that's actually pulling care out of the hospital and attracting patients in the different environments. So this is the guy that's like the minute clinics, like Walgreens New, like Rite Aid's place of the future. Jeff is one of those people. And when you start hearing some of the data there, it's pretty striking and what impact he's had. And another guest for us is James Mint. James, you can talk about what you're doing. I think this is really fascinating work, one that's incredibly important. And please share your background and what you're doing with your company clearly.
Yeah, great. Thanks so much, Sean. It's a pleasure to be here. So I'm Jim Min. I'm a cardiologist by training. I'm also the CEO of a company called Clearly. So we've developed a digital care pathway that really aims to try to identify people early with coronary heart disease, and then have coupled that with services and products that aim to really educate referring physicians, patients, and then have worked in concert with the ACC, the American College of Cardiology, to try to develop and treat disease protocols to really treat that phenotypic disease, like coronary atherosclerosis, and then quantitatively track the success of that treatment over time.
Yeah, and the reason I brought this in, and we talked about bringing this into this discussion, is all of you, and certainly the first 3/4 of this has been based on how do we manage patients that come in and are sick. That's essentially what we've been talking about throughout all of this. And a bigger question for us as we go forward is, how do we keep them from getting sick? How do we keep them out of the emergency room and out of the hospital? And that's what this discussion is really about. One of the things I'll throw into you, my personal experience is for the last 20 years, I've run a nonprofit foundation that does free cardiovascular screening and education for the public. We do a free carotid ultrasound, abdominal aortic ultrasound, and then we do peripheral arterial testing as well as blood pressure testing, and included in that a number of education programs we share with the community. And just as a backdrop, we screen everybody over the age of 60, everybody over 50 with risk factors, and everybody over 40 with diabetes, which is, those of you that know, flies right in the face of what the U.S. Preventive Service Task Force recommends, all of which are very unhappy with what I'm doing. But here's the data. So in my community of that, using that group, we've screened almost 70,000 people. It's almost 40% of the at-risk group in the county. 48% of the people that we screen have disease detected. 2/3 of that group are not on the appropriate, if you will, secondary prevention medications like an aspirin and a statin. 4% of them have disease bad enough that they do require an intervention, whether that's a large aneurysm, a critical carotid lesion, or critical PAD that they thought was arthritis. And so we've actually done this for 20 years, changed the way primary care is done, and cardiovascular disease got knocked off the top as the #1 cause of death in our county. And I think we're a big reason as to why. So if you look at the task force, it certainly came out just recently recommending against carotid screening. It's against carotid screening for the prevention of stroke, but the identification of plaque inside arteries, we certainly know is associated with, if you put them on an aspirin or statin, will reduce the morbidity by lowering the incidence of heart attacks and strokes. And so these guys, these two gentlemen for here, are actually attacking this particular problem and in a slightly different way. So Jeff, one of the things that you tackle is something everybody's happy with, and that is screening the public for blood pressure. Can you share with us just the scope of which Higgy actually gets across the country and how many people actually come through your doorstep? And I think it's important for everybody to see just how often people go somewhere else for medical answers. I think your data was pretty striking.
Yeah, I want to make sure I clarify what you said about pulling them out of the hospital. So I think part of we're trying to stratify and get the right people to the hospital and keep the
So
people healthy.
I'm Dr. Provocative here, Jeff. That's my goal.
I understand. But I think the provocative part of this is that, you know, we've done 372 million screenings over the last 8 to 9 years, right? And what we don't do well in this country is screen for some of the early risk factors for chronic conditions. And we don't have a good way of having frequent touch points to see what's going on. So what Higgy provides is over 10,000 free stations that are in the community, that are in trusted places, the grocery store, the pharmacy. I mentioned 372 million screenings over the last 8 to 9 years, a million tests a week. Pre-COVID, obviously a little down with COVID because of some of the CDC guidelines around this. 60% of the people screened have a chronic condition. But beyond that, if we just go down to Baycare, as one of our customers, for example, when we talked to Ed Rafalski, he's like, the problem is no one in our community knows what diabetes is. No one knows what hypertension is. No one even knows what cardiovascular is. So we've worked with the ADA, we've worked with the ACC, we've worked with the AHA. We run education programs on the platform. We provide screenings for hypertension, for obesity. We have the ACC risk test for heart attack and stroke. We have the diabetes risk test for ADA, for diabetes, or risk of diabetes. So these are all critical elements to get out into the community, because until the consumer understands these conditions, they're actually finding out. And the risk factor for a lot of people is they're feeling their chest, and they're feeling a pain in their chest, because that's where a lot of people are finding out they're having a problem with cardiovascular disease. We're trying to move that down, you know, so that people find out they have hypertension, they have obesity, how those risk factors are, so they get to a doctor and start managing this much sooner in the process.
So if you think about, for instance, Jeff, across the population, and I think some people actually don't realize this, if you look at hypertension alone, you got a third of the people in this country that have hypertension, it's undiagnosed. So we got 1/3 of the group running around, don't even know they have it. The next third, it's undertreated. And then obviously we get a third of it right. So if you think about a disease state that is as bad as hypertension and what it's contributed to heart disease and stroke, and 2/3 of the patients that have it aren't being treated well, I think this is an interesting opportunity to do that. And I guess the obvious questions that we have, how are you connecting, if you will, diagnosing hypertension into your stations, which is great service. People are going there, they're getting their blood pressure tested. It's fascinating how many people actually do it. How are you connecting them back into the healthcare system, which is a critically important next step?
You're really trying to get me in trouble. So we're an FDA Class 2 medical device. We do not diagnose the patient for this to make sure that I don't.
I'm trying really hard, aren't I?
Yeah, this is great. I look good in orange, I guess, is what you're trying to say. No, so our goal is
let's pause just for a minute on that, Jeff, though, because it is important. And I did that on purpose because I wanted this concept to actually come out. Because when people hear you have blood pressure stations, they're immediately thinking you're doing a diagnosis. And so it's important to pause at this. I did this on purpose for you to give that response. So it's important, again, to emphasize the fact that you're identifying particularly something, the wording that you use is critically important, but it's also important how you're connecting people back into the healthcare system.
So two flows. One is we're helping people identify unmet needs, whether that is they have a reading that's high and they need to get to a doctor, they don't have a doctor, or there are doctors that are sending them, like at Baker, they're sending a rush, they're sending the patients to our platform, and that data flows right back into their EMR. So they're using this to monitor patients in between visits. So it can either be a way to scalably manage hypertension. In case of Rush, they have over 100,000 patients with hypertension. They're not going to give 100,000 people devices to check in on a regular basis. So we can allow them to, change the way they access information from their patients by having them check in every week, every month at these stations. We also have home devices. So if they want to do home devices, we can support home devices, and we have an RPM service as well if they want to go on that path. So that's how we can help you manage your existing patients. And then we also can help bring new patients in the door. So some of them just need a doctor because they don't have a doctor. We did something with the state of Illinois. Those that are in the state of Illinois would not enjoy hearing this, but about 75% of people couldn't name their primary care doctor's name, which means that the state of Illinois, which doesn't have the youngest population and the healthiest population, they're not being managed well because they can't even name their primary care doctor, right? So how do we get you to the point to schedule an appointment with your doctor? So in that situation, we're really helping the person get connected. And in the rare situation, rare, it's 1 or 2%, you have a hypertensive crisis reading. We fought with the FDA, and we do not tell you that you have hypertensive crisis, but we do say that the AHA would recommend that you seek immediate medical advice. So we get those people to really think about taking action to go in And those numbers are pretty large when you think about this. 1 or 2% doesn't sound like a lot unless it's 100,000 people every day that are sitting down at the stage. So you're talking about real volumes of people that we're getting to the right place. So that's been historically what we're doing. I got my marketing person here. She's going to hit me, but we're going to also launch a care plan that is a digital care plan with the American Heart Association. So that's coming up here shortly. So maybe I'm teasing that out a little early, but we got a good crowd here. So we're going to enable a digital program around hypertension management as well, so that all that can be, coaching, that suggestions can be done digitally. Again, all this data can flow right back into your EMR if you want that data, or we just send information back to the consumer so they know what they should be doing and they can call the doctor back up. So really trying to be that extension of the PCP with our platform.
So Stephen, you're sitting here on board. What do you think, what percentage of your patients would actually identify you as their doctor? How do you think that would turn out?
I think my patients probably know that I'm their doctor, but there's a huge kind of undoctored population out there who just presume they don't get sick and don't need a doctor, or have never established care, or don't have health insurance, but kind of feel like they should check something up like through the kiosk test like that. So yeah, anything that kind of helps steer people towards the care and the prevention that they need sounds great.
Yeah, so, our goal is to get you connected to that doctor finder so you get that done. So we try to nudge you to say, there's a reason why you should have a primary care appointment every year at least. So that's what the state of Illinois wants us to say as part of being their employer. How do we get that PCP appointment scheduled at least once a year?
So one of the challenging things, and maybe Jeff, later you'll be willing to share your story, but one of the challenging things as a surgeon, and certainly as physicians, all of you know, we get a report that says there's a significant plaque in an artery. And part of the controversy is, okay, who needs to be treated and who shouldn't? And is it worth actually identifying a plaque early if someone isn't having symptoms? And the flip side of that is, we're not really good at identifying early who's going to have symptoms and who isn't. And so if you look, for instance, at carotid disease, there's a lot of carotid surgery that's done for asymptomatic, high-grade carotid stenosis, because we know a percentage of those are going to go on to have a stroke. We don't really have the greatest tools to know that. If you look at coronary disease, and I know I have some cardiologists, you can question me here, but I think the majority of acute coronary events still occur in plaques that are less than 50% stenosis because of plaque rupture. So it's actually the plaque rupture that's the difficult thing, and how do we predict that? Jim, how have you addressed that issue? Is there something that you're doing now that could help us be much more selective on who to be aggressive with?
Yeah, thanks for that question. Maybe I'm the odd man out. We don't use ultrasound, we use computed tomography, and we used coronary CT angiography as opposed to non-contrast coronary calcium scoring. But your statistics are spot on. If you look at risk factors to identify patients who will subsequently experience heart attacks, it's about 70% of the people who show up with heart attacks are considered low clinical risk by risk factors. And there's an 80% overlap of people for cholesterol for people who will versus will not experience heart attacks. So I don't think it works for populations. It doesn't work for people, pinpointing individuals who will have a heart attack. I think as a result, we've done exactly what you articulated, which is we wait passively for people to come to us to the ER or to the office complaining of chest pain or shortness of breath, and then we evaluate them there. But if you look at the statistics, more than half of the people who will be diagnosed with coronary disease will either be diagnosed by suffering a heart attack or dying from one. So it's very much a silent killer in the majority of people. So the tack that we've taken was based on a series of multi-center clinical trials that really identified that atherosclerosis is not a single disease entity, but it's a heterogeneous disease entity. And it's really the type of disease that you have that predicts the greatest risk. And I think the only way that you're going to be able to get to these people is to image them and to find that type, the sort of the adverse type of plaques that we see in the preclinical, pre-symptomatic setting. And that's sort of the thesis of what we're doing at Clearly.
It's interesting when we look at this, and you can think about the group that we have here. So you have Jeff on one end of the spectrum that's drawing patients into the healthcare system, trying to identify them and knowing they have need. Then we've got our acute care physicians that we have around here who are actually treating people that have problems that are out there. And then we have you on the other end of it, some advanced testing that may be able to more selectively treat those people so we don't have to throw medicines or interventions at everybody. It's an interesting spectrum. I wonder, the other panelists that are here, what is your response to both of these gentlemen and what they're trying to do in the community? And what's your immediate reflection on what role you think they should play in us going forward? You know, you guys in the emergency room are the lucky recipients, those people that get into trouble. What would you think about the more aggressive approach they're taking in, for instance, a retail space or more high end, referring someone, for instance, that you see in the emergency room for a Clearly study? What are your thoughts around that? I'm pushing you to go to a place that you're not used to going to, just to get your thoughts.
I think it'd be fantastic. It's kind of a wish list of ours. Anything that can increase access to the community and to increase health education in the community makes our jobs easier. So yeah, it really sounds incredible what you guys are doing, and I think that spirit is something all of us would like to take advantage of.
To agree, early recognition and non-reactionary medicine is where we want to be.
Ironic to get a bunch of ER docs on the same call who all wish we had better primary care and earlier identification of illness, but it's true. We see those folks, Jim, that come in with their MI with no prior diagnosed medical history, and it's not only tragic, but it's also frankly just harder for us. It's a lot easier when somebody comes in and has some known medical history to figure out what's going on with them than somebody who hasn't seen a doc in 15 years and just shows up acutely ill. So I'm fully on board.
To be careful with making sure that things are evidence-based that we're suggesting, clearly identifying hypertension early and getting people into treatment. And I would just put in for a plug that we really need universal health care like our friends to the north, where I myself did primary care, and when you don't have access or insurance, you're wasting your time with these people.
Yeah, from a primary care perspective, I guess screening sounds great. Prevention is always good, but I've seen plenty of things come and go over my career that maybe turned out not to actually move the needle on saving lives. We used to tell women to examine their breasts every single month, and it turns out that wasn't really moving the needle on keeping people from dying from breast cancer. PSA testing is another one that was hugely popular and maybe got overused and started causing harm. So anything, to help identify and treat heart disease before they have their first heart attack is great, but there's a pretty high bar for screening asymptomatic people and expending a lot of money and resources to know that it actually helps.
This is my favorite conversation. I really love this one because, as you guys can imagine, running a screening program for the last 20 years, I've had my share of debates with the task force. I've done so on a national level. And I think one of the interesting things, and this is a challenge for all of us, the way the U.S. Preventive Service Task Force looks at things is a little bit different than what you and I might think about things. They look at things, obviously, at a population health perspective, and they look at, for instance, carotid screening with respect to preventing stroke. They look for PAD, for instance, and preventing amputations as a great example. And so when you actually look at it to identify a patient population that actually could be successfully treated with better in moving from primary to secondary prevention strategies, no one's really actually looked at that. And in all of the task force recommendations, you don't see any of them that actually say that there's data that suggests it's bad. There's no data to suggest convincingly that it's good. And the two hypotheticals that they throw out there are, number one, is that there's psychological harms from having identified a disease state that may not necessarily kill you or cause you a problem. We can debate all day long whether that may or may not be the most ludicrous statement the task force ever makes. We could debate that. I think knowing that you have an aneurysm is a really important thing. Whether or not you need to have it fixed or not, I think you should know. But we'll put that one aside. The second one is there are going to be unnecessary interventions. And I think that's on us as physicians to make sure that we're treating people the appropriate way. And I think there's still a debate out there how often that actually occurs. And that's part of the discussion that we have here. I think part of the work that we're doing now is to try to give better data to actually prove that there is value, but answer the question that really matters. And part of that question is, can screening programs like what Jeff's doing or more selective testing like Jim is doing actually lead to better outcomes because you're drawing people into the healthcare system so that they actually get treated? And so understanding the bigger picture, and Lee, you sit in the middle of behavioral science empire with David Ash there. It's understanding the behavioral science of the way patients respond and to what things are also part of this equation that have never really been discussed as part of the screening. So we would agree that when the task force says general screening, that's right. I don't think a 12-year-old should come to a screening program for cardiovascular disease, but somebody over the age of 60 that has a 50% chance of actually having plaque within their arteries and they're not on appropriate medicine, that's a completely different conversation. And I would love to hear your response.
And I agree with you. I would argue that I wouldn't even wait for the unstable plaque. I would actually say the presence of plaque requires treatment. And so, doing that type of screening is probably the way to go to prevent events over time. It really depends on your time horizon. If you want to prevent MIs in the next year, then look for unstable plaques. But if you want to prevent MIs over a lifetime or over 10 years, then you just want to look for plaque and stabilize that so it never becomes vulnerable or unstable. And we have patients that say, I've been taking these medicines for 10 years, doc, and nothing happened to me. And I'm in the end zone doing the happy dance, spiking the ball. Of course, that's what I wanted to happen, right? And they wonder, why am I taking these meds? It's so that you didn't have the heart attack. And I think it's very hard conceptually for people to understand that concept, that it's very hard to count the event that doesn't occur. And so I think as clinicians, what I'm looking for is evidence to kind of help motivate the patient into action. So if I can show them that there's plaque there, or that their echo's abnormal, or that their blood pressure is high, that there's something objective, that's much more likely to motivate a patient than saying, take this medicine and take my word for it. So I do think that there's a role for kind of educating the patient about their own physiology or their own risk in order to motivate people to really stick with a preventive therapy when they may or may not feel any different one way or the other in the short term.
God, I love having you on this call. I'm bringing you with me the next time I debate the task force, people. Well, I think this is great, and I think it's important. I guess what I would suggest to actually all my panelists and all the listeners to look into both of these companies. I think they're doing actually really interesting things. And for more information, you can go to Higgy.com. I guess is probably the right place. And for Jim, is it clearly.com? Am I going to say that right?
It's clearlyhealth.com.
There we go. I knew I would get this wrong. I think it's really important to follow their work. I think it's important work that's out there. I think for all of us as physicians, moving to the left of that care continuum, and candidly, in many respects, it's talking about, we've moved ultrasound from the lab to your hands in the emergency room and the critical care and into the primary care doctor's offices, and testing into those retail offices that make sense, because engaging patients earlier, obviously, I think will have impact on their outcomes. I know we've got our compliance person, Kate, watching this, so she'll make sure I say all the right things, because I don't want to necessarily say better outcomes, but I think there's an opportunity where we can impact care and care in a better way. And I think that's the goal of all of us. I think we want to provide great care at the end when they show up in our door. We want to keep them from coming to our hospitals in the first place. And I think the combination of efforts that all of us are doing, I think will do that. I want to commend everyone. I think there's been some key points that have come out of every one of these segments. I think what we got out of the first segment was very clear, and Mike, please jump in. The cardiologists are adopting this, and it's great that they're doing it, but it's critically important that we have education part of it, and we understand what cardiac echo in the hands of a cardiologist can and can't do, and where it can impact care. I think the next crew, Mike's crew, have shown that clearly in the emergency room and in primary care, there's a role for point of care ultrasound. There are multiple applications that are going to be available, and training and education is, again, a key part of it. But it does impact the speed at which we can make some diagnosis, aid the diagnosis that physicians make, as well as speed the care in which we can deliver. Again, education is part of it. And I think Rachel brought up a good point. We've got to expand that outside of the academic institutions, the places where Nova and Rachel and Claire and others practice, so that we can get it into the community, and the role that they play is critical. I think lung ultrasound emerging out of this has to be something that everybody beats like a drum, because of all the things that may be the easiest to learn and the most impactful right away, in which we can impact care and people can embrace point of care ultrasound and be successful at it. And finally, I think there's some evolving ways in which, if we like to say targeted detection of high risk groups with early detection of disease and manage them differently in a proactive way, will have a big impact on the outcomes of these patients and addressing the issue of the world's #1 killer. So I'll commend all of you, and I'll flip it to Mike, and the rest of you want any final comments. Mike, to you.
Yeah, I mean, always hard to follow a summary like that, John, but I'd say one of the highlights for me of having everyone here, and thank you, and thanks for all the listeners, is it's pretty rare to get such a broad panel, multi-specialty of cardiology, emergency medicine, internal medicine, primary care, industry. It's amazing how these issues are universal, and whether it's early detection or early diagnosis or avoiding unnecessary or expensive testing or reducing readmissions, we all touch this every day, and this is something that all of our patients experience. So I think getting great multidisciplinary minds like this together to talk about these problems is a solid step towards making some real improvement. And yes, it's Heart Health Month, but next month it's still going to be cardiovascular disease is still going to be the leading killer of people in this country. So there's a lot of work to be done, and I'm just excited to be able to participate in any sort of small way with some of the great people involved here and elsewhere.
All right, thank you. Good night, all, and thank you very, very much for your participation. We've really enjoyed it.